The topic for discussion today is an important one, which is the hypertension in young adults, both for the exam and also in the OPD, to solve or approach a young patient who is presenting to the medicine OPD with hypertension. The topic is intended for MD medicine resident and also DM residents to get the approach. First, we will see what is it. What is this young hypertension or hypertension in young adults? If we take hypertension per se, the chronology usually occurs more in the old age group with some comorbidities. If the hypertension or the high blood pressure occurs before the age of 40 years, that is called as young hypertension. Few textbooks give the age as 50, some textbooks 35, but most standard we can say this as a less than 40 years. If an adult develop hypertension, that is called as young hypertension or hypertension in young adults. This is getting more importance as because of the current lifestyle and current scenario, more and more patients are developing high blood pressure at the young age. So what is the incidence? Up to 18%. On an average, if we say 18 people out of 100 might be having this kind of high blood pressure, that common it is. So that is why this topic should be very clear for the MD residents. Any hypertension we can take that can be because of primary or secondary causes. Primary means without any specific reason it is occurring, or because of the high lifestyle, we can put it like that. Secondary means there is some organic causes there. So in young hypertension also, it can be primary, which is the most common one, primary or the essential hypertension. Out of all 80 percentage, 80 to 85, 80 to 90, the value varies. For the bit clear concept, I have put this value 80 percentage is primary only, primary hypertension. The patient might be having some family history. So it comes in the primary or essential hypertension. The remaining 20 only is secondary hypertension. So most common cause of young hypertension is again essential or primary hypertension. Remaining 20% is the secondary hypertension. So what are the common causes? We'll go one by one. To make the approach clear, just you have to know four broad categories. One is the primary, which is very simple, where most of the patient, a medicine resident might think it is of primary, but you have to ask the history. What is the whether the hypertension is in the family? If in the family, at what age their parents have developed it? What is the extreme high level the BP have reached? Because in primary hypertension, it is unlikely BP will go to the extreme high range. Suppose if it is not primary hypertension, what are all the things you have to think in that particular patient might be involved? So for that, remember as kidney, endocrine, drugs, and the rare causes. With these four things, you have to approach the case. In the kidney, it can be renoparenchymal or the renovascular hypertension. In the endocrine, adrenal, pituitary, or thyroid can be involved. Drugs, the commonly used drugs, any side effect of a drug is there or not, so you have to ask the drug history. And the rare causes like autoimmune disease, obstructive sleep apnea, these are the things you have to think of if you are seeing a case of young hypertension. So primary, if not primary, approach in the terms of kidney, endocrine, drugs, or rare causes. We'll see it one by one. First, the renal. This is the most common cause of secondary hypertension in young adults. So in the MCQ from MBBS to MD, mostly whenever the hypertension word comes, the students always select the renovascular, so renal artery stenosis, renal artery stenosis. But clinically, if you take, the renal cause can be divided into two. Renoparenchymal causes, that means the kidney function is going down. The diseases which are related to the, per se, we can say kidney functions. Another one is renovascular, which is related to the kidney vessel, most common being the renal artery stenosis. If the renal arteries are stenosed, since the blood supply is less, the kidney, because of the homeostatic mechanism, releases more renin, which causes the hypertension. So that is the pathophysiology in renal artery stenosis. Another one is any stenosis secondary to fibromuscular dysplasia, atheroembolic diseases. Yeah, atherosclerotic. Atheroembolic occur all of very rare if the patient doesn't have any comorbidities. Atherosclerotic is common in the old age. It is one of the cause in the secondary. Accelerated atherosclerosis can occur in a familial hypercholesterolemic patient. If there is any genetic or other comorbidities, atherosclerosis can occur. So these are all the renovascular related causes, but this is not the second most common. Most common is primary. Suppose if they ask what is the most common secondary cause, that is renoparenchymal is the most common secondary cause. Most common secondary cause of hypertension in young adults, that is CKD, autosomal dominant polycystic kidney disease, nephritic or nephrotic syndrome. Nephrotic it is rare, nephritic it is common. Even a diabetic kidney disease, even though it is a separate, you can say renoparenchymal involvement is due to diabetic kidney disease. So sometimes that also comes under the renoparenchymal cause. Renal is involved, renal functionality is involved. So that is the most common secondary cause. In the MCQ nowadays, they are not giving the primary. If the primary option is not there, renoparenchymal, in that CKD, ADP, CKD, other kidney function related stuff comes. So this is the thing we have to look for. And other than this renoparenchymal cause, kidney vessel related, in which renal artery stenosis, fibromuscular dysplasia, any disease causing the renal vessel involvement comes. Next, endocrine. Clinically, what is the most common one we are encountering is the hypo or hyperthyroidism. Most common patient presents with isolated systolic or isolated diastolic hypertension. So thyroid you have to look for. The associated symptoms might be there. Other symptoms of hypo or hyperthyroidism from the history you have to look for. Other than that, adrenal can be divided into cortex and medulla. So if we say in terms of the cortex, primary hyperaldosteronism, Cushing syndrome, these are Conn syndrome, Cushing, hyperaldosteronism, Conn syndrome, the names. You can think in terms of cortisol, aldosterone, and the sex hormone, out of which cortisol, aldosterone high will cause hypertension. Primary hyperaldosteronism, cortisol related, Cushing syndrome, and the syndromes which are involved in this pathway, like Liddle syndrome, any syndrome which is behaving as hyperaldosteronism, those you have to consider. And the other one is the medullary causes. In that, pheochromocytoma, adrenal tumor comes, medullary adrenal tumor or cortical adrenal tumor comes, and rarely pituitary acromegaly. So in this, which is very common, is thyroid. This is somewhat rare. Acromegaly is very rare. So these are all the causes you have to think of. Obesity also comes, but that we will see it separately. This we are discussing with respect to the particular endocrine organ. So what are those? 1, 2, 3 subgetting. This we have to look for. Drugs. In the drugs, clinically, you should know which drugs commonly causes. Yes, there are drugs like cyclosporin, tacrolimus, those can cause hypertension, but most of the patient might not be on those rare drugs. Commonly, drug abuse, NSAID, cocaine, any nephrotoxic drug, or the patient is on any drug abuse or not, this you have to ask for. Apart from this, these immunosuppression drugs like cyclosporin, those are the drugs which is very very rare if the patient comes to you for the first time. Otherwise, they will themselves will give the history. I'm taking these drugs, then you can correlate. High caffeine or any drugs the person is taking as a gym supplement. These are all the common drugs which can cause a hypertension. So apart from this, any rare causes you have to look for in the search of secondary hypertension like renal artery Doppler, adrenal and all. Don't miss obesity and BMI. Obesity and high BMI is a very very important cause. Lifestyle related stress factors. This you have to look for commonly. And in that rare category, what are all the things come? Autoimmune disease like vasculitis, accelerated atherosclerosis, rarely coagulation of aorta, accelerated atherosclerosis, obstructive sleep apnea syndrome. These are all the rare causes. Autoimmune, coagulation of aorta, obstructive sleep apnea. Obstructive sleep apnea, you will get the history regarding the snoring, you will come to know. So these are all the things with respect to a approach what we have to look for. So we have discussed so many stuff. When to look for it? Why not all the cases are primary? Let us treat as primary. No, there will be certain clues you will get in the presentation. When the BP is not controlling with the single drug, always think of a secondary hypertension. When the patient present with end organ damage, which is called hypertension mediated organ damage in the form of retinopathy, encephalopathy, LVH, always think of secondary cause of hypertension. Extreme high BP is very very rare in lifestyle related obesity and primary hypertension. Extreme BP, if it goes, always think of renal artery stenosis and adrenal. Extreme like presentation only 200 220, like that. These are all the clues you will get. The patient presenting with end organ damage, single drug, it is not getting controlled, extreme high values. These are all the initial presentation. Sometimes even before starting the single drug, if it is primary, most likely it will resolve with lifestyle modification. So as I told, don't miss BMI, 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 BMI. Most important, and also take the history related to smoking, alcohol, sleep, whether the patient is getting adequate sleep, stress related, psychogenic factor, you have to know how much stress the patient in. These are the common causes in the OPD where the BP might be in the range of 140 to 160. It won't go above that with these. And especially many patients will come and say, sir, I'm having so much stress in life, but my BP is 190 plus. Always look for secondary causes because 190 plus unlikely to go in a primary or stress related factor, unlikely to go. So this is the clue you have to look for. So in the OPD, if a patient comes with a BP of more than 140/80, how to approach this thing you should be keep in mind. So for that, what is the most important one is the history. Try to fit in primary, renal, thyroid, obesity, metabolic syndrome or diabetes. Obesity, I hope as a medicine third year, you will be having some high order thinking. Don't tell I didn't tell regarding diabetes. Obesity in turn, you have to think regarding metabolic syndrome, regarding diabetes. These are all the comorbidities the patient will be having. So the history, most important one. Once you start getting the history, keeping these diseases in mind, you will get the particular clue. From there, you will continue with the evaluation. As I told, a BP should be in the extreme range. Always think of secondary. Not controlling with a single drug. The patient have other symptoms like palpitation, intermittent sweating, or particular diagnosis related clue, you can pick up that particular secondary cause. Primary unlikely to go. Always check the BMI. These are the important stuff. BP, history, and keep four things in mind, which is primary, renal, endocrine, most common thyroid, and followed by these. Okay, now that we have got the history, BP is on the higher side. So what are all the investigation you have to get? Whether it is primary or secondary, if you are suspecting this adult have developed it at a younger age hypertension, always better to go for investigation before starting the treatment. So investigation, we can make it as tier 1 and tier 2 investigation, because we can't go and directly check for adrenaline in all the patient because it won't be cost effective. So that is why you have to selectively go with investigation one by one. So first the investigation to pick the basic secondary cause or basic whether all the functions of the organs are correct or not. Complete blood count, kidney function test, liver function test, kidney function test, look for urea, creatinine, uric acid, whether because high uric acid is a marker of metabolic syndrome, urine routine microscopy to look for any proteinuria is there or not, ultrasound abdomen to look for both the kidney size, HbA1c to look for the dysglycemia or whether the patient is having lifestyle related problem. ये तो नहीं, डायबिटीज भी हो गया, हाइपरटेंशन हो गया एंगेज में बिकॉज ऑफ द पुअर लाइफस्टाइल. Thyroid, which is being most common. Even during my residency, MD residency, 3 or 4 of my friends in that MD circle had some kind of systolic or diastolic isolated hypertension, and in the subsequent evaluation they was found to have hypothyroid. So this is also very very common. Once you do this investigation, you will get the clue from which we can proceed with the second tier of investigation if required, and also to look for the end organ damage. End organ damage, not the doctor. Hypertension mediated organ damage. In the end organ damage to look for ECG, del echo to look for left ventricular hypertrophy, fundus to look for the hypertensive retinopathy. Urine ACR is much sensitive test to detect the albumin in the urine. Kidney might also be a victim of hypertension also. Kidney might also get damaged. Hypertensive nephropathy. So to pick those conditions, these are the investigation to pick the clue. These are the investigation to look for the end organ damage. Doppler specifically to look for renal artery stenosis. So these are the initial investigation you can get in a patient presenting with young hypertension. And subsequently, if you think the patient is having any other particular cause like adrenaline, adrenal related stuff, you can go for the specific test related to adrenal, specific test related to pituitary if you want. Obstructive sleep apnea, sleep studies you can plan. These are all things you can plan. So when to start a treatment, this though we will see in the next video, as the time is already crossing to more than 20 minutes. We'll stop here. We'll close. Bye bye.